Welcome to Let's Talk About Mental Health. I'm Nels Kloster, and I'm an addiction psychiatrist. I work in Southern Vermont.
And I'm Robert Stack. I'm a licensed alcohol and drug counselor.
And tonight we have a guest on our show, one of our favorite and esteemed colleagues, Dr. Lesley Fishelman.
Thank you.
And we've brought her back because we want to talk about, well, continue with our criticisms of the use of pharmaceuticals, but in particular around this opiate crisis and all that we're seeing in the news these days about the dangers of these. And of course, Dr. Fishelman, you've been as a part of this sort of realm of medicine for decades now.
That's right.
That wasn't
Decades.
very kind, was it?
Decades.
That wasn't very kind.
Thank you, Dr. Kloster.
I appreciate experience.
It's okay. So from 1988 until the year 2000, I was the director of a pain program at the Harvard Community Health Plan, which was a closed panel HMO. And when I started there as a clinician in pain management, there were almost no patients on opiates for chronic pain. By the time I left in 2000, I was doing 4 or 5 consultations a week on opiate management of patients who had been started on opiates and were having trouble with dependency or overusage. And that was in the space of 12 years. In that time, the program started out as a holistic, multimodal pain management program. We generally had 20 people in each cycle, which lasted probably 8 weeks. And the options were other psychotropic medications that might help with anxiety and depression, and this form of treatment. And patients didn't necessarily love the idea that they had to do it the hard way, but they did it the hard way, and the results were actually quite good. But then what happened in the mid-90s was that the hospital surrounding this HMO began to prescribe opiates in larger amounts. And so patients in the HMO wanted to be treated in the same way as people outside the HMO, so they began asking for opiates as well. And there was a tremendous amount of pressure on the delivery system of clinicians to provide these medications for patients which were not provided before. And so what was happening was the beginning of this epidemic that we now have with so much prescription drug abuse and so many people who switch prescription drug abuse with opiates to heroin because it's cheaper.
Now, when you say HMOs, does that mean they were employed, they were working somewhere, they were part of functioning in society, or were they more?
No, this was a closed panel HMO similar to Kaiser Permanente on the West Coast. And people were either employed or they got their HMO membership through Medicaid because they had a certain Medicaid population. But most of the patients were working people. And prior to the mid-90s, opiates were not used. But what happened is that, and this is the good part of the story, doctors in the 80s began to realize that people with cancer and people with acute pain were often under-medicated, and they really were under-medicated. So here's an example. My younger son broke his leg, a really severe broke, which was an avulsion fracture. This leg, the top of his...
Is the bone showing, right?
Yeah, it was a terrible break, and he required screws in his legs and surgery and a whole bunch of things. And they put him on Demerol for 3 days, and then they took it away and they substituted codeine, which is almost homeopathic in terms of opiate action, right? It's 1/200th as powerful as Percocet. His blood pressure shot up to 210 over 110.
A young, healthy guy.
Young, healthy 15-year-old. And I said to them, put him on Percocet. And they said, we can't put him on Percocet because he will become addicted. And I said, I'm a psychiatrist. If he becomes addicted, I'll put him in detox. And this is actually an interesting story about opiates. So they put him on the Percocet, which he continued for 2 weeks at home. And then he said to me one day, and this is really very telling, he said, "Mom, I don't know what stuff you have me on, but it used to help the pain and now it's not doing anything, so stop giving it to me." And he was still having a lot of pain, but it was a different kind of pain, and so I stopped it. He had no withdrawal. He was never on more than 15 milligrams of Percocet a day. Okay, so, and in addition, he was in high school. He was a freshman in high school, and he did not know the name Percocet. In 1990, none of his friends knew the word Percocet.
Yeah.
Now, do you think that's even possible in a high school student in
no.
2015 or 2016?
And even they know the difference between codeine and Percocet.
Correct. So that's just an interesting story. Or the fellow who had an opiate history, a problem with heroin, who had ulcerating cancer lesions in his throat, and no one would put him on opiates because he could become addicted to them, and he couldn't swallow and he couldn't eat.
Yeah.
And, you know, he got sent to me as the pain management specialist, and I said, put him on opiates,
Right.
you
For
know,
the
just
remaining
don't raise the dose.
Yeah, for the remaining months of his life.
Right, right. So that needed to change. And in the sort of desire to change that, what happened is that a group of clinicians got together and started a pain society and began talking about using opiates to reduce the pain burden on patients. The original research done on this consists of 2 papers. One is this paragraph that I was telling you about, a 1-paragraph article in the New England Journal of Medicine, which talked about opiate use in inpatients in the hospital with burns or other kinds of pain problems. And basically the take-home message was only 1% of them developed any problem with addiction. Now, none of these patients were followed as outpatients, okay, or started on medicine as outpatients. They were all started in the hospital. And so this isn't a study. The fellow who wrote it said it wasn't a study, but because it was in the New England Journal of Medicine, which is the holy grail of
very well respected.
Right, the holy grail of medical literature, people picked up the citation, meaning the actual reference to this, without ever reading the article, which is, I don't know whether this will show up, but it's this paragraph.
It's nothing.
It's nothing, and it wouldn't make it into any medical journal. And they started quoting that. And then there was another article in 1986 by a fellow named Portnoy, who was a pain management specialist from New York, who treated 38 patients, outpatients, with chronic pain, with opiates, and only 2 of them who had priorly had opiate problems became addicted. So that became the second reference. Now, all of his patients were followed very frequently. They were managed very, very tightly. And the dose of pain medicine used was the equivalent of 30 milligrams, if I have this right, 20 milligrams of Percocet. Mm-hmm. That was the highest dose used in the study. And that became quoted as another indication that these medicines were not addictive. And we were way overestimating the addictive potential of opiates.
That amazed me, because I think it was just last week, NPR did, I thought, a very well-informed piece about opiate epidemic, as everybody's calling it, and they started off with a quote by a doctor, and what he said was, physicians seem to feel that they've been given free license to prescribe these very strongly addictive and terrible medications. And you're thinking, okay, this is some expert I haven't heard of right now. But then what they told you is this was a quote from like the 1800s. And so when you look back at, if it's such common knowledge then, like soldier's disease with morphine addiction from the Civil War, how could we have been so sort of short-sighted or not aware of the potential, danger or risk around doing exactly what we've come to do now?
Yeah, it's pretty amazing. The same thing happened in the 20s after World War I. where lots of people became addicted to opiate medication, and there was this huge backlash again to pull away from opiates, and that lasted from the 20s until the early 90s. So it is a pendulum thing. But this particular story has more moment, meaning it's more complex than any previous story, I think. Because what happened here is that based on these 2 articles, which really are not research that either of the people who wrote expected to have this impact, this became the talking point for starting to treat chronic pain with opiates, and also changing the quantity of opiates available. And what happens to clinicians, to doctors in practice, as opposed to what you would call physician leaders or physician trendsetters, is that they rely, as clinicians, you rely on information you get from those people who do research and who are experts, because there's no other way to get the information. So there was a tremendous sort of onslaught of information that said, really, you could do this, that we have this data, which is basically these 2 articles, that's it. We have this data, and as the American Pain Society, we think that you can do this without worrying about it. And that, in fact, we think so much of this idea that you have to treat pain actively that we're going to make pain the 5th vital sign. And that happened in the early 90s, that pain became, I think I have that right, maybe the mid-90s, that pain became the 5th vital sign. So blood pressure, which is a number, pulse, which is a number, respirations, which is a number, and something called the pulse ox, which is the measurement of the amount of oxygen in your blood, is the 4th vital sign, or fever is the 4th vital sign. Those are all numbers. And pain, which is not measurable by any stretch of the imagination, was the 5th vital sign. And what they did was they had to figure out how you measure that. So what they did was they asked the patient, how severe is your pain on a scale of 1 to 10, 10 being off the chart, the worst you've ever had, and 1 being very mild. And that's how that vital sign was measured.
Yeah. And this is very impressive, because I remember, when people talk about evidence-based medicine now, the idea of sort of having studies and data behind something, the idea of the randomized controlled trial, where we set this up ahead of time, we ask the questions we want to answer, you control it with placebo or sugar pill, you try to make people blind to what's happening. Basically, the doctors don't know, the patients don't know who's getting the real thing, who's getting the other thing, and that's considered the top of evidence for it. And then you sort of whittle down to then a bunch of studies that are somewhat similar but not the same, as you call meta-analysis. And as you farther and further go down the line, these things, a small study in one place, what do the experts think about this thing, those are like almost no evidence. That's the bottom of the barrel for what you could pretend to call evidence around what you're doing. And yet it took on such a life, and I'm wondering, you're describing a lot of peer pressure when you talked about the pain clinic that you were working with. It was almost like if you didn't do what everybody else was doing, then you would have no business.
Well, I think that was part of it. So the other part of the story, though, is that, so for an HMO, you have to provide the same services in-house as our outhouse. That's really kind of interesting. Out of house. So the reason the pain program got started in the first place was because the hospitals outside had pain programs that were multimodal pain management programs, where you did meditation and relaxation and cognitive behavioral therapy and all of these things to help people get control of their pain and not let the pain control them. Okay? And at one point there were 1,000 of these programs or more in the country. What happened was that those pain programs began to prescribe opiates, the ones outside of the system I was in, and the patients in the system expected the same thing as what was going on outside. But here's how that happened. So the American Pain Society develops this fifth vital sign. Lots of people go out on the lecture circuit talking about the fifth vital sign. JACO, which is the Joint Commission on Hospital Accreditation, develops the fifth vital sign as part of a requirement for assessment. And once you assess it, you need to treat it. So if you have a temperature of 102, you have to show resolution. If you have a blood pressure that's very high, you have to show resolution to satisfy JACO. If you have pain of a 10, you have to lower it to satisfy JACO. Now that can't be done in the hospital in any quick way without opiates. The only way to do it is quickly.
I've heard you explain this before, and I'd love to, if you would do it again. The difference between giving opiates with someone with a broken leg in acute pain and giving somebody opiates for chronic pain, which is where a lot of people get in trouble.
Right.
And how I've someone that you worked with got to a point where that dose was so high it wasn't working anymore. Right. And I remember you explaining that. I wonder if you could explain that again.
And maybe a little translation too. I mean, acute in medical speak means it's new, it's right now, it's very intense, and chronic means sort of ongoing, long-term, maybe not quite at the same level.
So a way of looking at this without charts and stuff like that is that opiates. When I went to medical school, which is in the in the 60s, right? Opiates were seen, and I always saw them, as medicines that work very well in the short run. So for a day to 2 weeks, they work extremely well. People don't develop dependency on them as long as the dosages are kept within a certain range. And for acute pain, that's perfectly appropriate. So the treatment of my son's leg for 2 weeks with this bad break was perfectly appropriate. Now, he developed after that some other kind of pain that lasted a couple of months and almost reached the level of what you would call chronic pain, which is pain that has lasted 3 to 6 months or 6 months or more, depending on how you do it. Now, for that kind of pain, opiates may work in the beginning, but the tolerance, the body's ability to manage, to use up the medicine, to adjust to any dosage, is overwhelmed by the medicine within a period of a month or 2 or 3, and there is a need to increase the dose. Even if you're not trying to game the system, there's a need to increase the dose.
What they call tolerance.
Which is due to tolerance, has nothing to do with wanting to get high or anything. So if you increase the dose, then that works for a little while, and then you have to increase the dose again. And what you do is you get yourself into a position where you're on way too much medicine, which, if you then try to stop it, will produce withdrawal.
Now, the body produces its own opiates, and that's why we have opiate receptor sites.
Right.
Does the body stop making opiates when it begins to take opiates from the outside?
When there's a high enough dose of opiate taken in from the outside, the factory that makes opiates in your body shuts off. It just shuts off.
Our endorphins, like
the endorphin
sex,
system,
drugs, and rock and roll, these things
because
that bring pleasure.
The exorphins, the opiates that come from the outside, are much stronger, in molecular weight and all of that stuff than the opiates that your body makes. So your body stops making it, and then when you stop, you have no endorphins, so everything hurts. You get shaky. Everything that endorphins were doing for you is not available to you because you have actually no endorphin factory in your body that's operative, and it takes a month or two for it to get back online.
Does it also affect mood? Does it affect how they feel about themselves? Because,
Sure.
I mean, is it...
Opiates are mood elevators, and Percocet, which is the opiate that, well, not Percocet, but oxycodone, which is the opiate that really is responsible for this horrible epidemic we're having now, is a mood elevator in itself. Not all opiates are mood elevators, but endorphin is a mood elevator. In other words, if you could somehow really make endorphin itself and give it to somebody, it would elevate their mood.
Oh, yeah.
And oxycodone, which is the active ingredients in OxyContin, is a mood elevator. Okay?
And I think that's one of the things that I've noticed. When I was a kid growing up in Newark and people did heroin, you know, you couldn't find it sometimes. They would get dope sick. I mean, you know, they would, you know. But nowadays, I hear people talking about they're almost terrified of going into withdrawal. It's so scary for them. I mean, it's like the worst thing that can happen to them is not to have the opiates. And I don't think it's just physical. I mean, to me anyway, it just seems different. It seems like they feel so depressed or something when they don't have any opiates. So it isn't just that they have goosebumps or, you know, there's something more to it. And I've wondered what that was. Is it something, is it different than heroin when they're doing like oxys or when they're doing other types of?
I don't think that's been studied.
Okay.
I think heroin is a mood elevator, and I think heroin, people who are dependent on heroin, when they don't have it, they are depressed. But keep in mind that this is a new generation with in some ways, less tolerance for distress than people from my generation as a group. And my generation has less tolerance for distress than my father's generation, who went through the Depression. I think there's this undercurrent in the culture now, which makes us less resilient than, let's say, our grandparents or our parents.
Right, so less willing to put up with distress,
and less willing, and at some
suffer.
level, less able to put up with distress. Yeah.
Because one of the struggles I have sometimes in trying to talk to people about recovery is that they don't really want to have life without opiates.
Right. Right.
And when I try and convince them that no, there is recovery, you can live without opiates, and you know they're very, I don't know, they're very stubborn about it almost. Like, I don't want to go off it. I mean, and when you talk about people going on Suboxone or methadone, even when at low dose, and you say, you know, you can live without it, they don't have faith in that. They don't. They don't believe me.
Yeah, and that's, you know, that's a really interesting question. You know, I mean, that's a whole other realm than maybe this discussion about how this happened.
Yeah.
But there is in our culture, I think, particularly, I think all through the socioeconomic spectrum, a kind of loss of connectedness that gives you a sense of hope about your future. And also, you know, if you sort of mess up and get caught, it's even more so because you can't ever catch up. You can't ever catch up to get where you would need to be able to feel good about yourself. It's really, really hard to do. So you have to sort of settle because you don't have any structure holding you up. You know, community structures are much less powerful than they were. Religious structures are less powerful than they were. And so what sustains you, what gives you, you know, what gives you that ability to sort of take this on and really work with it for the sake of your own self-development. I mean, I think the culture has problems in that regard. We're much too used to having it quick and easy, and this is really, really hard for people.
And I think part of it is that by the time some of them get to that point where they want to quit, they have burned all the bridges.
Right.
They are disconnected from family. They are disconnected from social systems. And the only only
Right.
social system they have is other users.
Right.
I mean,
That's right.
I mean, it's a bit of a perfect storm in
Right.
a way, because you've got this sort of low tolerance, you've got this very strong profit motive with pharmaceuticals, this expectation that I should be given a medication to fix my struggles. And I mean, I've wanted to sort of take on the blame through medicine, you know, that the doctors did this to people, but it's just one more piece in all these other pieces that come about.
So let's talk about another piece, though. So in 1995, 1996, Purdue Pharmaceuticals started marketing OxyContin, and they marketed it, and I remember this, they marketed it as a less addictive form of Percocet or oxycodone, and that was because it was timed release. And they said and told physicians over and over and over again that it was not addictive, that it was really not very addictive. And they had their sales force of thousands of people telling doctors that it was not addictive. And in fact, in 2007, they got sued successfully, and they had to pay $635 million for lying about this, because they really did know, like the cigarette companies knew. And so there is this piece where the doctors were marketed to use this medication, which started at 30 milligrams, right? 30 milligrams was the lowest dose, which is the maximum amount you can take without getting dependent on the meds and going into withdrawal. In other words, if you take 30 milligrams a day for a month, your factory is going to shut off and you're going to have some minor withdrawal. Okay? Now, in addition, the doctors were being, at that point, measured for productivity, so they never had time to talk to their patients about all of the things you would need to know before you gave people a prescription. The patients were told it was their right to have the medication, and so what you got was the perfect storm. Physicians were, and physicians were also measured in terms of patient satisfaction. So if you didn't give people opiates, they weren't satisfied and you were criticized. If you didn't prescribe them, you were violating the patient's rights, and at some point, the medical boards of states would sanction you for not prescribing opiates. Now, mostly this was for, terminal illness pain, but also for chronic pain. And doctors could get sued or reported to the medical board because they weren't prescribing opiates. So you have this aggressive marketing from the corporations. You have the physician leaders telling you these drugs were safe, which they weren't. And you have pressure on you to prescribe because you don't have time to talk to patients, so the quickest thing is a pill, and that's what they want anyway.
We're almost running out of
Sure.
time, and I got to ask you, it may be unfair. Do you have some suggestions how we can do something about what they call this epidemic? What do we need to do as a society?
Because even though there's this wide recognition that this is a problem, an epidemic, you often, on the individual level, yeah, fine, them but not me. And even now, the Centers for Disease Control and Prevention has come out and tried to publish some guidelines around controlling the prescription, and they're getting pushback,
Right.
not just from the pharmaceutical companies, but from other organizations as well around this.
Right. And that's the American dilemma. It's a bit like the plan to sell marijuana in Vermont. In other words, this is what the people in the culture want, so this is what you should do as a physician, even though it's not necessarily sensible. And so I think we need guidelines. I think we need very careful guidelines. It's not that no one should get pain meds, but you should get them in limited quantity. You should be monitored for the same way that you're monitored if you're in a methadone program or a Suboxone program. If you get regular opiate prescriptions, we should go back to a more holistic treatment approach, which does work. It actually does build up endorphins if you meditate, do relaxation, and change your cognition. And we have to put the genie back in the bottle, but boy, once you take the genie out, it's hard to do. It's really hard to do.
I'm almost thinking like physicians have to be like better parents. I
This
mean,
is
that's
gone
sort of a model, right?
so quickly. Thank
Yeah.
you so much.
You're so welcome.
It's
It's always
been
fun being
wonderful.
with you guys.
Glad
It's
you're back
wonderful.
sometime. Thank
Yeah,
you.
yeah.